Good evening. This is Dr. John Bennett from Miami, Florida, broadcasting. Tonight we have a continuing video hangout in the series of Parkinsonism education with world-renowned Parkinsonism educator Dr. A.Q. Rana, a neurologist from Toronto. And tonight, Dr. Rana is going to be talking about Festination of Gait in Parkinsonism, and you, as well as me, will find out what that is. Good evening, Dr. Rana.
Good evening, Dr. Bennett. It's always a pleasure to talk about Parkinson's disease.
Oh yes, yeah, we like to listen to you too, because you seem to know a heck of a lot about it. So we'll start things off with the first question. What is Festination of Gait?
Festination of gait is a very typical disorder for Parkinson's disease, and it's described as walking faster with a shuffling pattern and then difficulty stopping to avoid obstacles. So it happened to me about a few patients which presented with festination, because sometimes it could be a presenting complaint. Very interesting story of a patient. He used to take a bus every day from his home to work. So one day he was a bit late, and so he came to the bus station. So he was standing, and the bus was, when he arrived, the bus was standing, but the moment he reached, the bus had started to move. So he started running to catch the bus, but he could not catch the bus. The driver did not see him probably, so the bus left. So he was running behind the bus, and then he should have stopped when the bus left, but he could not stop, and he kept on running. So then he fell down, and he sustained some lacerations on his face and some injuries. So he was taken to ER. So when he was taken to ER, the ER doc examined him, and he noticed a very subtle pill-rolling tremor. They addressed his lacerations and everything, but they made a referral to neurology. They said he has a small tremor of his hand. So when he came to me, so when I asked him that how can I help you, so he did not report the tremor or Parkinson's, because he had no idea. He was not familiar, or he was not sure about Parkinson's. But what he said, well, I am fine. Well, I said, you had been referred to me. He said, no, I actually had some injuries on my face and head because I was trying to catch a bus. So then I fell down. And but I went to ER, and they did the stitches. I'm fine now. So then I read the note of the ER doc further about the tremor. Then I started taking more focused history about the tremor, about the slowness of movements, the loss of sense of smell. Then I realized that this patient has Parkinson's, and then when I asked him detail about the episode of catching the bus and all that story, so then I realized that this was the festination of gait he was having, and that led to his assessment. Another patient I had, he was accompanied by his daughter. So the daughter reported that he either doesn't walk, he just sits at home all day, or he runs. He doesn't walk anymore. I said, what do you mean? He said, no, he doesn't walk. He just, when he gets up, he starts running, and then he can't stop. So this is a very typical description of festination, because what happens in festination, the legs of the patients, they try to catch up with their upper body's forward motion, and patients are not able to stop when they reach the target, and this leads to fall. In my study of history, I'm a fan of history, so I like to study the history of movement disorders. Mm-hmm. So the first description which I noted was even before James Parkinson. In 1776, John S. Sager, he wrote in his text, he wrote, I saw a man in Vienna who was above the age of 50, and this person was running involuntarily, and he was not able to keep direction to avoid any obstacle. So likely he was describing the festination of Parkinson's disease. And the age group was right. He said above the age of 50, which is the usual which is the usual onset age for Parkinson's disease. And then James Parkinson in 1817, when he published his essay Shaking Palsy, so he described festination, and he said the propensity to lean forward becomes invisible, and the patient is thereby forced to step on the toes and forepart of the feet, irresistibly impelled to make much quicker and shorter steps, and thereby do adopt unwillingly a running pace. So he described it as a running pace. So this gait fascination is quite typical for Parkinson's disease. It's not usually seen in any other neurological conditions, and it's associated with freezing, the phenomena of freezing of gait. They have some relation, and it seems that there could be some commonality in the pathophysiology of these two conditions, which may include a disturbance of central timing mechanism or something like this.
Why do Parkinsonism patients have difficulty turning?
The patients with Parkinson's disease have trouble turning, and probably there are many factors which may contribute to this. They have decreased stride length, they have decreased speed of walking, and their base is also narrow. In addition, they have the impaired axial rotation. So the truncal impairment usually occurs in the beginning of Parkinson's disease, and they have the deficits in the range of motion of trunk when they are walking, and this does correlate with the severity of the disease. The reciprocal oscillation between the pelvis and thorax, which are normal in every human being, and they are not dependent upon the speed of walking. So these oscillations are impaired in these patients. So probably the impairment of oscillations, decreased speed of walking, stride length, narrow base, as well as the slowness of movements. So all these factors, they combine together, and these patients therefore need more steps to turn effectively, and the trouble turning becomes a major problem in Parkinson's disease patients. And some patients do freeze when they're trying to turn. They just their feet get glued to the ground, and they feel that they can't lift them up, so they go through this difficulty of turning.
Are there any strategies which can help these patients that have festination of gait and difficulty turning?
Festination of gait sometimes could improve with medications. When you initiate these patients on levodopa, their regular speed of walking improves, and festination may respond somewhat, at least partially. In addition to this, the education of the patient about walking slowly, reminding them again and again that they should walk at a slow pace does help. Also, if patients have trouble with their balance because of fascination, then asking them to use a walker would also help. And in some cases, asking them to use a walker which is only two-wheeled would be more helpful if patients have more trouble with the balance. If you give them a four-wheeled walker, the walker goes very fast. So there is a chance that patients, when they're festinating, their walker is also going fast, and they may not be able to stop. But if they have a two-wheeled walker, then the speed of walker would be much less. So therefore, the festination can be at least partially overcome by these methods. The difficulty turning is also, you need to educate patients more that they should turn slowly. They should take multiple steps, and they should be patient when they're turning, and especially they should be careful while they're turning. And use of walker does help these patients.
Very good, Dr. Rana. Anything to add before we leave on this topic of festination of gait and Parkinsonism?
I think screening these patients for especially difficulty walking is very important. Fascination is such a symptom that usually patients would volunteer, or a family member who accompanies them, they would volunteer that they have these issues. So you can address that, but difficulty turning is something that patients may not report to you, or they may not pay attention. And difficulty turning is also a major risk for falling. And some patients are quite hesitant to use a walker. So you have to screen them, educate them, and also tell them, especially that trouble turning could be a risk for falling, and if they fall, that could lead to head injuries and brain hemorrhage, or it could lead to fractures. And fractures cause a loss of independence, and they have to go to hospital. I try to discuss the consequences of falls, so that patients try to understand and try to follow the instructions of using assistive devices, and they don't fall, because fractures could lead to very serious consequences. I have seen patients who had fractures. They had to get admitted to the hospital, and once they were admitted to the hospital, they got PE, and so many other problems. They got pneumonia, infections, and then these complications keep on happening to some patients, and they take weeks and weeks to stay in hospital. So I think the best part is, they say the prevention is better than a cure. So the best part is to educate these patients to prevent falls. The fall prevention campaigns are very important, and the review of strategies which may prevent falls and help patients in turning and prevent these balance issues is quite important tool in reducing these problems.
Yes, we'll try to use this platform to try to educate, to help for prevention. Thank you, Dr. Rana, for Fenestration of Gait. This can be seen on the channel Parkinsonism.tv, and we'll be back tomorrow night with another in the series of Parkinsonism Hangouts, educational hangouts. Thank you, Dr. Rana.
Thank you, Dr. Bennett. Bye-bye.
Bye-bye.